Welcome back to the American College of Surgeons Bulletin Brief from the front lines, Surgeons' Voices. With me today is my friend, Dr. Sameh Emile. Dr. Emile is an associate professor of surgery at Mansoura University in Egypt, and he is rapidly becoming internationally renowned for his collaborative efforts and meta-analyses. Dr. Emile recently became an initiate of the American College of Surgeons, so we're delighted to also welcome you, Sameh, as a fellow of the American College of Surgeons.
Thank you very much, Professor. I'm very delighted and privileged to be inducted as a fellow of the American College of Surgeons. It's a great honor that I really appreciate.
Well, thank you for being a fellow, and thanks for all your hard work in these high quality scientific studies which you produce with your team. And I mentioned collaboration. The ACS exemplifies collaboration, both global and interdisciplinary. And in this particular paper in Journal of the American College of Surgeons that we will share with people, you talk about laparoscopic guided transversus abdominis plane block for postoperative pain management in minimally invasive surgery. And you conducted a systematic review and meta-analysis with people from a variety of institutions. So the first question I wanted to ask is, you've involved people here from Sudan, obviously Egypt, you from Mansoura University, one of our Cleveland Clinic, Florida alumni, Alan Saber, who's now up at Beth Israel in the Northeast. You have a surgeon here from also from Thomas Cataldo is here from the Harvard system. And you have folks involved from a variety of other places, including Madrid and the UK.
Yes.
So could you tell us, please, how you came to that particular compilation of people from Spain, from UK, from Boston, Sudan, and Egypt?
Okay, I just want to make one thing clear at first. The first author and the lead investigator, Dr. Haytham Hamid from Sudan, he was the one who took over the work. I mean, I was invited by Dr. Hamid to collaborate in this work because I have published a randomized trial on laparoscopic tab block in bariatric surgery, in obesity surgery. So he invited me first to publish a meta-analysis on laparoscopic tab block in bariatric surgery, including my randomized trial. Then he invited this stellar faculty you have mentioned from all over the world, and he invited me, and I thank him very much for inviting me. And he actually led the work in a very fantastic way. He distributed the task, and the end result, this publication in the Journal of American College of Surgeons. So I have to attribute this coordination and this effort mainly to Dr. Hamid from Sudan.
And it also looks like Dr. Thomas Cataldo from the Harvard system was the senior author on the paper, and then there were the others from Madrid and the UK and from Beth Israel as well. Can you tell us, firstly, what was the aim of this study published in Journal of the American College of Surgeons?
If we want to talk on a global aspect, on a broad aspect, we all strive to confer a better outcome for our patients post-operatively. The whole concept of minimally invasive surgery is to minimize trauma to the tissues, accelerate recovery, and minimize pain. However, even though with minimally invasive surgery, patients complain of pain, and I mean, in the US, they are usually prescribed opioid. In Egypt, we are now ceasing on using of opioid. I mean, the last 12 months, we have reduced the opioid prescription a lot. But in the US, I know the opioid prescription is a common trend. So different techniques are used to decrease the opioid prescription and opioid consumption. One of these techniques are the regional block, namely the laparoscopic transversus abdominis plane block. The transversus abdominis plane block was mainly introduced via ultrasound guidance. Because via ultrasound, you can view the transversus abdominis plane precisely, you can guide your needle, you can see the distension of the plane as you inject the local anesthetic. However, the use of ultrasound machine and being conducted by the anesthesiologist, all of these are a little bit of technical problems in a busy operative list, in a long day. the anesthesiologist may not be very free or have enough time to do this. So instead, surgeons decided to do the tab block via laparoscopic guidance, via a technique was previously introduced by laparoscopic surgeon. Then randomized trials started to compare the surgeon-induced lap tap via the anesthesiologist-induced ultrasound-guided tap, and this was the purpose of the meta-analysis. We wanted to know whether the laparoscopic tab is as effective as ultrasound-guided tab block and or other modalities for pain management or not. This is what the main core of the meta-analysis.
Thanks very much. Would you be able to share the results? Firstly, how many papers and or how many patients in those papers you identified? And then secondly, of course, what was your finding?
Yes, this actually was a PRISMA compliant meta-analysis. It was adherent to the guidelines of the PRISMA checklist and so on. I've prepared a quick overview presentation of the results of this meta-analysis. Actually, the meta-analysis included 19 randomized trials that included 1,983 patients. And the trials were actually not very homogeneous. Some compared laparoscopic tab with ultrasound-guided tab. Some compared laparoscopic tab with local infiltration analgesia or LIA, and some compared with inactive control like placebo or even none. However, it was interesting to find that none of the studies compared laparoscopic tab block via epidural analgesia. None of the 19 studies controlled for epidural analgesia. And now I'm sharing a quick overview of this meta-analysis that included a lot of faculty from around the world. We have no conflict of interest to disclose. First, the primary outcome of the meta-analysis was pain score at 24 hours. In brief, the laparoscopic guided tab block and ultrasound guided tab block were similar in regards to pain score at 24-hour, whether at rest or during movement. Laparoscopic tab block was better than local infiltration analgesia for pain at rest only, not at movement. On comparing lap tap with inactive control, of course, laparoscopic tab block was better than inactive control, either placebo or no intervention, at rest and at movement. This indicates that laparoscopic tab is an effective modality for pain management. It is as effective as ultrasound guided and more effective than local infiltration analgesia. This is for the pain score at 24 hours. However, for pain score at 4 hours and 48 hours, again, the lap tap and ultrasound tap were similar, and the lap tap was better than local infiltration analgesia and inactive control at 4 hours, but not at 48 hours. And this is one message we have to deliver clearly. The problem with regional blocks, namely tap block, whether ultrasound guided or laparoscopic guided, they are short term. They can relieve pain for 24, 36 hour maximum. But at 48 hours, their effect starts to wane off. And this is quite logical and quite reasonable. However, in order to mitigate for this problem, now we have long-acting local anesthetic, and we even have catheter for continuous infusion of the anesthetic agent for over 72 hours. And this, I think this will be the future strategy. Now regarding opioid consumption, we have this interesting contradictory result. The lap tap compared lower consumption of opioid than ultrasound tap at 48 hours, but not at 24 hours. On the other hand, the lap tap had lower opioid consumption than local infiltration analgesia at 24 hours, but not at 48 hours. We don't actually have an explanation for this interesting observation, but overall, we can say that tap block, whether laparoscopic or ultrasound guided, reduce opioid consumption for up to 48 hours. And this per se, in my opinion, is considered a very good advantage, because if you can reduce opioid consumption within the first 2 days after surgery, this may help to decrease the severity of the opioid crisis and the persistent opioid status. Regarding hospital stay, the lab and ultrasound tap were similar, and lab tap was associated with shorter stay than local infiltration analgesia. Satisfaction, again, the lab and ultrasound tap block were similar, and the lab tap was better than infiltration analgesia and inactive control. When we did a couple of sensitivity analysis, a question has arisen whether you should give the tap block before surgery or at the end of surgery. This is a persistent question. Even in my practice, we ask ourselves, do we have to do the tap block, whatever the technique you are using, before we start or at the end of surgery? Actually, it didn't matter. Yes, the preoperative and postoperative laparoscopic tap were similar, both conferred similar pain score and similar opioid consumption. Now, in the context of ERAS studies, there were 3 studies that applied the ERAS protocol frankly and clearly in their methods. The lab tap was associated with lower pain score and lower opioid consumption than inactive control in the ERAS protocol. However, in the non-ERAS studies, or the studies that didn't actually and clearly state they use the ERAS protocol, the same result was achieved. So in conclusion, I can conclude the whole results of the study that the laparoscopic tap is safe and effective for pain management. It is as effective as ultrasound guided tap and more effective than local infiltration analgesia in regards pain control, opioid consumption, and patient satisfaction. We recommend future studies to focus on the procedure-specific outcomes, like the type and the dose of local anesthetic, and of course, as I mentioned, the continuous infiltration using catheter, and to compare laparoscopic tap with epidural analgesia.
Thank you very much. That's fascinating information. I think that it's certainly very clinically relevant and going to help us in our practices. Well, congratulations on yet another meta-analysis. You certainly are becoming, as I mentioned earlier, internationally renowned for putting out these high-quality, PRISMA-compliant meta-analyses and systematic reviews. One element you didn't cover in your study, and I don't know if you have any information about it, is cost. If there's any difference in cost between ultrasound guided and laparoscopic guided blocks?
Yes, it was a problem that none of the studies actually focused on this particular element, the element of cost. So in the meta-analysis, we cannot actually conclude any useful information about this. But from our practice, the main advantage of laparoscopic tap is that the surgeon himself or herself can do it even before or at the end of surgery without the need for ultrasound machine and without the need for the effort of the anesthesiologist. So are now saving a machine, which is the ultrasound machine, and saving the effort of another physician. This could be reflected as a cost, yes, if we calculate the overall cost of the procedure in terms of the machine used and the other elements. I think the lab tap would be more cost effective.
So based upon your study, what is your recommendation for those of us who are doing surgery? Should we be performing a lap tap block on every patient undergoing minimally invasive surgery? If not, are there certain exclusion criteria, certain patients in whom you wouldn't do it? And would you do it before or after the procedure?
What I recommend for every laparoscopic procedure to do a tap block, whether ultrasound guided or laparoscopic guided. But the main catch, for laparoscopic guided, you must have the sufficient experience. Otherwise, you'd be injecting the local anesthetic agent in the wrong plane, and it will not confer its required desired effect.
Okay, so thank you very much. So for those surgeons who might not be familiar, and although it's not part of your meta-analysis, but it's clearly part of your practice, how does one identify the correct plane?
To identify the correct plane via laparoscope, actually there are different sites for the tap block. If you are doing colorectal surgery, is different from cholecystectomy, is different from bariatric surgery. So different locations to inject the needle or to put the needle. However, we must be aware that the first trick is whether you are using a cannula or a spinal needle or whatever the route of entry, you must not violate the peritoneum. don't penetrate through the peritoneum. And you see the tip of the needle just beneath the peritoneal membrane, but you didn't penetrate it. Then you withdraw the needle a little bit backwards, and you feel a release. This release is the needle passing through the internal oblique muscle. So now you are in the midway between the transversus abdominis muscle and the internal oblique. So you are in the correct plane. You start injection of the local anesthetic, and you know you are in the correct plane when you see a bulge. The peritoneum at this area is bulging, but it is not ballooning. And there is a difference between ballooning, which means you are injecting just beneath the peritoneum, and bulging, which means you are injecting in the correct plane, which pushes the peritoneum a little bit forward.
Thank you very much for that very clear, cogent explanation. Congratulations again on your research, and thank you for taking your time today to share it with us. I look forward to collaborating with you and to reading many more of your studies where you're collaborating with others around the world. Keep up the great work. Hopefully when this COVID pandemic is eventually behind us, we'll see each other in person at an upcoming clinical congress or elsewhere in the world.
I'm very delighted and very honored, privileged to be interviewed by you for the American College of Surgeons Bulletin, and I congratulate you for being assigned as the Vice President of the Board of Regents of the American College of Surgeons, a very well-deserved position, and I send you my heartily congratulations for this.
Thank you, Dr. Emile, and stay safe.
Thank you very much. Stay safe, and hope to see you in person again.